I always feel like a bit of a fraud standing up here because there's much more that we don't know than we do know with motor neurone disease. So I really, and it's good to see lots of friends in the audience and people that we help with motor neurone disease. Those of you who know me, I often say to people how we look after people, and the philosophy behind the service that we run at Macquarie is that the patient is the expert. They are the expert of them. Their family are the expert observers. And we're the experts of the pills, potions and poisons, and more of what we don't know than what we do know. So I'm, as the first speaker, going to talk broadly about motor neurone disease, and we're going to talk about what we do know about therapies that improve quality of life and survival in motor neurone disease. I'm going to touch a little bit on the problems with current therapies and therapeutic trials, if I swear, I serve advance notice that I'm occasionally let loose the odd profanity. And then we're going to talk about challenges, the challenges that face us in defining this disease and working out how we have to stop it. And I can't stop this disease. It's guys like Brad sitting in the front row and the scientists who are asking biological questions. They're the guys that are going to end up with the tools to stop this disease, whatever they are. Does anyone know who this is? Am I carrying, or do you want me to come up a bit? Gee, that's the first. That's the first that a mic's had to be put up for me. That's better. How's that? Much better. That's really very directional, isn't it? Anyone know who this is? Yeah, who said that? Well done. Thomas Alva Edison. And Edison is attributed this quote that genius is 1% inspiration, 99% perspiration. Okay, who's this guy? Now don't say Freddie Mercury.
Tesla.
Yeah, well done. Nikola Tesla. So Nikola Tesla was a Serbian physicist, Croatian physicist, shouldn't call him Serbian. He was and a true genius behind Edison's founding of GE, and has numerous inventions, died penniless. But Nikola Tesla, in response to Edison's quote, had this quote: if Edison had a needle to find in a haystack, he'd proceed at once to examine straw after straw. I was a sorry witness of such doing, knowing that a little theory and calculation would have saved him 90% of his labour. And that's what we need to do with motor neurone disease. We need to get smarter. So, and again, amyotrophic lateral sclerosis was first defined in the literature by Charcot, the father of modern neurology, who practiced in Salpêtrière in the 14th arrondissement in Paris. So what I'm going to do is broadly define motor neurone disease and the different sorts. So motor neurone disease is a group of diseases that preferentially affects motor neurons in the cortex, in the motor nuclei of the brain stem, the anterior horn cell in the spinal cord, and it preferentially affects the corticospinal tracts. But we do know that motor neurone disease affects many other cell types as well. So it largely targets these cells and the corticospinal tract and the lower motor neurons. Still can't catch it? Is that better?
Yes.
Wow. And Charcot famously, when he looked at the spinal cord of someone who died from motor neurone disease, it showed preferential damage. And you can see the pallor here. So this is a myelin stain of a spinal cord of someone who's died from motor neurone disease. And this is the anterior horn down here, and it's very atrophic, and there are virtually no cells in there. And these are the sensory tracts, the dorsal columns. And this stains for myelin, and so the intact axons that have myelin on them are quite healthy and they stain well. But the lateral corticospinal tract, which takes the signals from the brain down to the spinal cord, is damaged. And when you actually feel the spinal cord, it's hard, and hence the name sclerosis. Now, there are no two people with motor neurone disease that have exactly the same symptoms or signs. And the proportion of cells that are affected in motor neurone disease help to determine the major symptoms and signs that patients have. So you hear people talk about lower motor neurons and upper motor neurons. Now, upper motor neurons are the cells that sit up in your cortex, and they send the processes all the way down to the spinal cord and brainstem nuclei to talk to the lower motor neurons. Your lower motor neurons then send an axon out to talk to your muscle. Now, if your lower motor neurons are unhappy, you get various different symptoms. You can develop weakness, cramping, twitching, incoordination, and reduced endurance or fatigue. At the time of weakness, 70% of the nerve cells talking to that muscle are gone. And the doctor gets out his tendon hammer and taps you and feels your muscles and mutters into their beard. And they're looking for specific different signs. And they're actually grading weakness. And again, just to emphasise, by the time the neurologist feels that your muscle is weak, you've lost 70% of the nerve cells talking to that muscle. There's wasting of the muscle or atrophy. And doctors are often looking for these fasciculations and these macrofasciculations, the little twitching in the muscle that we see. And reduced or absent reflexes. So if your lower motor neurons are very damaged, then your reflexes drop out. Now, if the upper motor neurons sitting up here in your brain are affected, then that produces a different pattern of symptoms and signs, and the proportion of the upper and lower motor neurons then determine how you present. So often with upper motor neuron dysfunction, stiffness or clumsiness occurs, slowing, incoordination, and a specific pattern of weakness can develop, where weakness is more evident in the arm extension, and inflection in the leg. So you might have difficulty just lifting your big toe up when you're walking, and it might catch when you're tired. And again, the upper motor neuron has different signs. So the doctor will feel your limbs, and they're feeling for this concept called spasticity, which is a velocity-dependent stiffness in the muscles. They tap with the reflex hammer, and we can elicit brisk reflexes and abnormal reflexes that propagate. Often the doctor will tickle you on the foot, and that's not just for fun. It's actually to look at these primitive responses, because the corticospinal tract is involved in suppressing very primitive responses that you have as an infant. So as an infant, if you tickle a baby's foot, their toes will splay and spread. And then as we start to learn to walk, we suppress those reflexes. And then as the corticospinal tract from the brain is affected, those primitive reflexes come back. And we can determine a specific pattern of weakness called pyramidal weakness. Now, often when people talk about motor neurone disease, they say it's a rare condition. Well, it's not. The incidence is 2 to 3 per 100,000 per year. So the incidence is how many new people will develop motor neurone disease in a year. The prevalence is how many people at any point in time have motor neurone disease. But the lifetime risk of an Australian dying from motor neurone disease is 1 in 250. So if you think about the state of origin last Wednesday night, even though that was painful, there were 80,000 people there. So 1 in 250 of the Australian population is 80,000 people. So this is not a rare disease. In our last 15 years running our motor neurone disease service, our survival range varies from 3 months at its most aggressive, and our current longest survivor is 32 years with the same disease. Why? It's more common in men than women for reasons we don't understand, except for some specific forms of motor neurone disease, such as bulbar onset of amyotrophic lateral sclerosis, that's more common in women than men, again for reasons we don't understand. And it's not just a little increase, it's 9 to 1. The mean onset is in the 6th decade, but in our clinic, again over the last 15 years, we have a range of 19 to 90. It's estimated that there are 1,400 people at any one time in Australia with motor neurone disease, but there's no true community prevalence or incidence study that's been performed in Australia. So this is a slide that I prepared last year that I can't explain. So this is taking Australian mortality rates from 1986 to 2009. And I think the slide speaks for itself. Why this is, we don't know. Is it case ascertainment? Are we getting better at diagnosing it? Are we using better terminology? Are death certificates getting more accurate? We don't know. Another area that confuses some is how motor neurone disease is classified. And again, some of that is to do with the terminology that's used, but just to try and look at that just for a minute. So you hear the term amyotrophic lateral sclerosis, or the Americans call it Lou Gehrig's disease. And that is a pattern of disease where you have involvement of both the upper motor neuron up here in the cortex and the lower motor neuron in the brainstem and spinal cord. Now, some patients just have lower motor neuron involvement. Formerly, they used to be called progressive muscular atrophy. And again, that can be a little bit confusing because there are some specific genetic forms of muscular atrophy, and it's probably worthwhile leaving that term to those patients. We see patients and we term them flail limb onset, so where you just have a floppy, useless arm or leg. And then sometimes patients can develop upper motor neuron features later on, and you can see in this Venn diagram that they overlap a little bit. So this flail limb onset, or as I said in textbooks, that's sometimes called progressive muscular atrophy, is the next most common form of motor neurone disease, and that's around about 30% of our patients. Bulbar onset of motor neurone disease, so where speech and swallowing is affected first, often mistaken for a mini stroke. Often GPs erroneously send patients to the ear, nose and throat surgeon first, and then second, and then third. And slurred speech should never go to ear, nose and throat surgeons. They don't understand slurred speech. And it's very common that I see patients who've had quite a few visits to ear, nose and throat surgeons before someone actually twigs and the person gets sent along to a neurologist. There is a very rare form of bulbar onset of motor neurone disease that just stays purely upper motor neuron, or corticobulbar. And we have several patients with this where the limbs stay well preserved and strong and mobility, but speech becomes a major, major issue. And then lastly, there's a very rare form of motor neurone disease, Janet, perfect timing, called primary lateral sclerosis. And primary lateral sclerosis is a very uncommon form of motor neurone disease that just affects the Bett cells up in the cortex. Now, why do we take so much time classifying this? Why is it so important, apart from keeping me off the street, to actually classify different forms of motor neurone disease? Well, the form of motor neurone disease is the major determinant of survival. Even though the biology appears to be the same, we have to ask ourselves, is this motor neurone disease, one disease entity, or much more likely, motor neurone diseases, where we have multiple different genes that can produce the same similar clinical phenotype, and we also have other biological processes that are more important in some patients than others, producing different phenotypes. So the other way to think about motor neurone disease increasingly, and has been for quite some time, is inherited forms versus familial versus sporadic forms. So most of the time motor neurone disease comes out of the blue. It's like winning a reverse lottery or perverse lottery. But some patients have an inherited form of motor neurone disease, and at Macquarie we look after 9 families with inherited forms of motor neurone disease that has its own dimension. So for about 10 years, about 7 sites around Australia have been collecting systematic data on clinical phenotype and how that correlates to survival. So even when all things are equal, access to non-invasive ventilation, Rilotech, all sorts of multidisciplinary care, when we look at survival, and again this is just talking a little bit more to this clinical classification, where upper motor neuron versus flail limb, so arm weakness or leg weakness versus typical ALS. And when we look at survival, your presentation is the major determinant of survival. So these are survival curves of people with primary lateral sclerosis. So, and this is out at 15 years. And this is bulbar onset of amyotrophic lateral sclerosis, where your survival is threatened much sooner. Versus, say for example, flail arm onset. And when you put all the different subtypes of motor neurone disease, survival curves are very different. And there is some overlap. And again, I have patients with bulbar onset of amyotrophic lateral sclerosis who are out 10, 15 years. And I have other patients with flail limb who are in a lot more trouble much sooner than that. So you can't necessarily extrapolate back to the individual from these survival curves. That's not the point of this. The point is that the phenotype, how you present, is a major determinant, and I think is giving us really big clues into the biology of motor neurone disease. And if we are deaf to this, then our therapeutic trials, if you have unequal groups of these different subtypes of motor neurone disease, are doomed to fail. And currently, most of the trials that have been performed to date do not take this into account. So just to go back to familial versus sporadic. So about 10% of patients, when we sift through their family history, there will be perhaps someone may have died last century of creeping paralysis, you'll see in a death certificate, or muscular dystrophy. And when you actually hunt through their family history, it actually looks more like an inherited form of motor neurone disease. In the early 90s, the gene that was identified was as copper zinc superoxide dismutase type 1. It was first discovered by a guy called Erwin Fridovich in E. coli in the 1960s. And this enzyme in bacteria is really important in detoxifying oxygen metabolites within cells. But it doesn't seem to be working that way when we have mutations in this gene in familial forms of motor neurone disease. There may be various different ways that this abnormal gene produces an abnormal protein that ends up preferentially damaging motor neurons, because this enzyme, this copper zinc superoxide dismutase type 1, is present in every cell in the body. So again, even though we are now 20 years down the track from identifying SOD1 as a cause of motor neurone disease, and more than 110 mutations have been identified, some of which are more common. For example, in Australia we have a very common gene abnormality called V148K, and that gene abnormality doesn't occur in North America. And in North America they have two very common phenotypes or genotypes, A4V and G93A, and that has a very typical age at onset and progression, whereas V148K, our patients have started at the age of 19 and other patients are into their 70s without any manifestation of motor neurone disease. So again, there's further environmental influences or perhaps epigenetic influences on that gene abnormality that makes the gene become manifest. So formerly it used to be written that the gene determined how old you were and what form of motor neurone disease you got in SOD1, but that's not the case and it's not accepted now. And again, this is a source for further study so that we can work out what are the tools that make someone's gene stay dormant and another person's gene become active so that we can silence it. Over the last 4 years, from work done at the Anzac Institute with Garth Nicholson and Ian Blair, 2 new genes were identified, TARDP and FUS. And these genes are really important in RNA processing. Now, exactly why a ubiquitous gene, again expressed throughout the body, then preferentially damages these motor neurons, we still don't yet understand. In November of 2011, workers from North America, from the Mayo Clinic and from National Institutes of Health identified another gene called C9orf72, working in collaboration with researchers in Scandinavia and in Wales. Now, this gene abnormality is really curious. So it's what's called a hexanucleotide repeat, where you have a sequence of 6 nucleotides that get repeated multiple times. And if you have too many of these repeats, then it may turn into motor neurone disease, or it can sometimes look like another disease called frontotemporal dementia, and it can overlap between the two. And some people with this C9orf72 expansion don't get any problems. Now, this expansion is not in an expressed part of the gene. So SOD1, TARDP and FUS are all in expressed parts of the gene, whereas C9orf72 is what's termed an intron. So it's a silent bit of DNA, seemingly. But very recently, researchers in Munich identified that what happens is that these expansions undergo autonomous transcription. So what that means is that what should be a silent bit of DNA, the cell mistakenly starts expressing that. And you could see the experiment, I think it was in Science, wasn't it, Brad? You could see the researchers sitting around the coffee table thinking, now, what if it doesn't get spliced out? What if the cell switches on? What would that look like? And so they went away and made some specific tools to measure that, and then they went and had a look and they went, bang, there it is. So half a dozen really bright young guys sitting around a coffee table in Munich exploded this field. And that comes back to my comment that it's guys like Brad and the scientists that we fund here in Australia are going to make the changes. It's not going to be the pharmaceutical companies. It's not going to be people like me sitting in the clinic looking after people now, here, today. It's going to be these guys. Now, often it's said to me, how come my diagnosis was delayed so long? How come my GP missed it? Or how come I saw this galah and this idiot and had this surgery? And I see lots of people who've had surgeries before someone goes, uh-oh. this is a difficult disease to diagnose. And again, it's similar to, you know, before you have children, there are no prams on the street. Then as soon as you have children, there are prams everywhere. So when you're looking for them, you see them. So when you're sensitive to motor neurone disease, then the diagnosis becomes apparent. And again, mistakenly, some people say that, you know, it's a diagnosis of exclusion. I don't think it's a diagnosis of exclusion. And you do have to rule out a whole heap of other diseases, but motor neurone disease, in my mind, is an active diagnosis based on history, careful physical exam, supported by neurophysiology and imaging. So how we make the diagnosis is fraught with error, because even with the most stringent criteria, called the Ellis-Scorial criteria, around about 1 in 5 people with motor neurone disease don't ever fulfil the criteria for motor neurone disease. It tells you that the criteria are screwed. They're just hopeless. But it's the best thing that we've got. So the diagnosis is evidence of lower motor neuron degeneration, upper motor neuron degeneration by clinical exam, because still today, in 2013, our best method of detecting upper motor neuron involvement is a tendon hammer? Really? But it is. Progressive spread of symptoms and signs, and that's the thing with motor neurone disease. It tends not to jump around, it spreads to contiguous areas. And then the absence of other disease processes. And when I see patients that get sent to me for motor neurone disease, I'm hunting, I'm sniffing. I don't believe what anyone else says. I go through everything right from the get-go. Because there are some lookalike conditions. And probably around about 1 in 25 people who come to see me don't have motor neurone disease. So we look really hard. Kennedy's syndrome, which is a genetic syndrome that occurs in men, often accompanied by type 2 diabetes. Radiation myelopathy, because radiation therapists never think that radiation can actually do damage to anything. You sort of think, well, why are you having radiation? But again, radiation myelopathy can look like motor neurone disease. We hunt for metabolic disturbances, so an overactive thyroid, overactive parathyroid. This beastie often gets mistaken for motor neurone disease, multifocal motor neuropathy, which is a rare form of inflammatory neuropathy that just picks off motor nerves. Post-polio syndrome, and there are a few others. There are still major questions regarding the biology and pathogenesis of motor neurone disease that we don't yet understand. Why are motor neurone neurons selectively vulnerable? And there are many partial answers to that. One is that they are very active cells biologically. They also don't handle calcium particularly well. So all motor neurons, with a couple of exceptions, don't have much in the way of calcium buffering proteins. So anything that disturbs how calcium activates in the cell can lead to big problems. Interestingly, the motor neurons in your body that have good buffering, such as the neurons that control your eye movements and the neurons that control your bladder and bowel, they don't get damaged that early in motor neurone disease. So they seem to be protected against the process that occurs in motor neurone disease. But these cells are also huge. So the neuron is about 100 microns, so 100 millionths of a metre. And the axon that that little cell supports, in some people, if you have a little motor neuron sitting up here in your lumbar spine and you have an axon going down to your foot, well, not in me, but in some people it's more than a metre. So it's 100 millionths of a metre cell structure supporting a process that's over a metre. And that's huge. So to draw an analogy, if you had a cell body that was the size of a beach ball sitting in Birmingham in the UK, the end of the axon would be sitting in Berlin So that little cell structure is doing a huge amount of work. And that, I think, is also one of the reasons why motor neurons are vulnerable to whatever process it is that's going on. Now, whenever you see a slide that says the pathogenesis is multifactorial and the person who's talking waves their hand, it means that we've got little bits of evidence for each of these things, and we've talked about abnormal calcium homeostasis. Glutamate excitotoxicity is the thing that underpins the effectiveness of riluzole, but it may not just be that. Genetics and epigenetics, so how our genes interact with the environment. And again, Roger Pamphlet's done some really clever work looking at how your genes in the rest of your body actually vary with the genes in your nervous system. Abnormal mitochondrial function, so the mitochondria are very important in producing energy within the cell. And then also Brad's going to talk about intracellular processes, and no doubt, and this problems with normal cellular constituents and how they get folded and handled within the cell. So something seems to go wrong with the messages, and whether that's chicken or egg, these guys are working out. Stunned silence. I've bored you to sobs already. Reminds me of a bad joke, I guess. Just trying to think of the phrasing. What did the psychiatrist say to the gastroenterologist? With Freuds like these, who needs an enema? I'm sorry. At least we're awake. Good. Just checking. Does anyone, while we're sitting there about pathogenesis, does anyone want to throw anything at me, or do we want to save it to the end? Because I'm happy for you to... No tomatoes coming yet? Later. Excellent. So we do have a tablet that works a little bit in motor neurone disease. And it's this drug called riluzole, and the trade name is Rilatec. And that was identified in the early 90s, again from Salpêtrière from Paris. So the brains behind the Motor Neurone Disease service in Paris is a friend of mine called Vincent Meninger, who's just retired. It's now being taken over by a guy called Pierre Salachas. And Meininger's clinic looks after 900 people with motor neurone disease. They have 5 full-time neurologists. They have 4 floors, a sole building, just to looking after patients with motor neurone disease in Paris. And so riluzole works a little bit. And again, not to take anything away from riluzole, it does slow down the momentum of this disease a little bit. Is it just through glutamate antagonism? Probably not. Matthew Kiernan over at Prince of Wales and others have shown that there's an effect of riluzole on sodium channels, and there may be an independent effect on neuronal survival, but that's quite tricky to show. And there are 2 large trials that have been published, randomised controlled trials, that show improved survival in motor neurone disease. It's generally well tolerated. The sceptics say that's because it doesn't do anything, which I disagree. I think that there are some people who respond to riluzole and some people who don't respond to riluzole, and we have patients who stay static and well and their disease progression decelerates on riluzole, and we have other patients that they may as well chuck it in the toilet for all the good it does for them. So, and this is out of the original publications from the New England Journal of Medicine that shows that riluzole improves survival compared to placebo at 50 milligrams at 100 milligrams a day, which is the usual dose. And there are some patients who go up to 200 milligrams a day, but usually the side effects start to cut in. How am I going for time? Multidisciplinary care. Now, multidisciplinary care dramatically improves survival. And you think, well, how could just looking after people well improve survival? Well, it does the same in diabetes, it does the same in heart failure, it does the same in cystic fibrosis, where kiddies who are looked after well survive dramatically longer than kiddies who are not looked after with integrated care, with patient-centric, patient-focused care. And again, this is data from Ireland, published by Brian Traynor, that shows the comparison between the survival from a general neurology clinic versus a motor neurone disease clinic. So our motor neurone disease service, we currently look after 140 people with motor neurone disease. We see between 60 and now 70 new people a year with motor neurone disease, and we offer comprehensive diagnostic and therapeutic management for people with motor neurone disease. And it's meant to be patient-centric. We try to do the best that we can. We sometimes don't, and we appreciate it when people give us feedback about what we can do better. It needs to be integrated, timely, reactive. Unfortunately, it is not funded particularly well. So we're very grateful to the support we get from the Motor Neurone Disease Association of New South Wales, who give us around about 10% of what it costs to run the motor neurone disease clinic. We get a lot of private donations. Love him or loathe him, Ray Hadley coughs up out of his own pocket to us, as does 2GB and Sony Music, and he is extremely generous. The Monstar Foundation, so in March every year there's a fundraiser out at Pennant Hills run by 3 young blokes, and they have raised over $1 million that goes split between Motor Neurone Disease Services and MND New South Wales and the research, and also to the STAR Association. We get no direct funding from state or federal sources, none, not a cent. Non-invasive ventilation, I'll just touch on. There has been shown in randomised controlled trial over 7 years ago that it improves quality of life and survival in people with motor neurone disease. Done and dusted. So why, apart from Enable, can't we get this therapy funded by the government? It's disgraceful. Why do most respiratory physicians, with some exceptions, run a mile rather than help us with our non-invasive ventilation? Because in motor neurone disease, when you're in REM sleep at night, you don't get enough oxygen in your blood. And we have quite a few cases that we can actually show that we change the rate of progression of the disease by adequately ventilating patients who need it. So this is the publication. I won't dwell on this, but this is the major perception why non-invasive ventilation is not offered or used. Patients may not be offered or accept NIV due to a fear that prolonged survival in the face of increasing disability in a terminal disease is burdensome and diminishes rather than improves quality of life. False, 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 bullshit. I'll flick through this. And it's not just for people with chest weakness. We do see patients that we ventilate with bulbar motor neurone disease, and you have to pick the right patients, and it's quite tricky. So you need to have a clever, resourceful respiratory physician. And we've actually worked very closely with ResMed, who've generated quite a few masks and sorted out situations for us in the home. So ResMed up at Norwest, and they've been really good. The other major company is Respironics that help us. The important thing is that it needs to be considered. You need to look for nocturnal hyperventilation before it occurs. And it needs to be offered to the patient, not served up, well, oh, you can try this, but it really doesn't work. But with an attitude that says, well, this is a therapy, I think it actually will help you, give it a try. If it doesn't work, then, you know, we've tried. There are many questions in non-invasive ventilation. So this was a trial that started at the onset of respiratory failure, but we suspect that if you can pick people who are going to get into troubles with breathing at night before they're symptomatic, that we may be able to have an influence on the rate of progression of disease. And we don't know the answer to that. Is it cost effective? And again, there are various different ventilators that we can use. Do we really need a $15,000 $15,000 ventilator versus a much cheaper one that does the shot. Again, it's difficult, and it's not an area that we have a lot of information on. A very important thing is what are the things that determine compliance with non-invasive ventilation. So if you just give people a complicated machine and a mask that doesn't fit and send them home and say whack it on at night, it doesn't work. So the introduction of NIV has to be done by people who know what they're doing, usually as an inpatient in hospital. What's the most effective form? So there are various different forms of ventilating. Got to go. I've been talking too long. And what's the burden on both the patient and the carer? Because we need to be very careful of that. So I run out of time, but my last 2 slides, or 3 slides. Now, dexpramipexole trial failed earlier this year. They ran 2 phase 3 side by side, and the company came and asked me, would you be part of this trial? And I said, I'll ask you one question. If you get the answer wrong, there's the door. So dexpramipexole is a therapy that's used in Parkinson's disease. It's a dopamine agonist, and it's one of the enantiomers, one of the subtypes of a Parkinson's medication. So I said to the MD, what's the biological premise that an enantiomer of a Parkinson's medication will work in a disease as complicated as motor neurone disease? And he said, I don't know. I said, there's the door. And I've got bricks thrown at me by some of my colleagues, and in fact at the international meeting a couple of years ago we had a long discussion about this, and some people's view was, well, we don't care how it works just as long as it works. They pissed $80 million up against a wall on a trial that was never going to work. And they ran another phase 3 trial before they'd even reported the first phase 3 trial. Why? Wall Street does not tolerate early failures in neurodegenerative disease trials. They're very expensive, they're a big gamble, but it was never going to work. So they did it for share price. Currently GSK are doing the anti-no-go therapy, and there are a couple of units here that are involved in that. Again, I'm not involved in that trial because I don't understand the biology of how a protein that's expressed up in muscle by giving a systemic therapy is going to change my beach ball sitting in Birmingham. So it's attenuating Berlin, and we're hoping to make Birmingham better. Doesn't make sense. So it has to at least, survive the plausibility test. There's currently a trial going on, a safety trial of fingolimod, which is a therapy that's used to attenuate the immune system, run by the ALS TDI. And again, I was over there 2 months ago wanting to see their data, and their answer was not yet. We've got to get better at measuring this disease. It's amateur hour. The ALS FRSR, which is the scale that gets applied. Whenever you come and see, we do little ticks and crosses, and this is the lingua franca of measuring motor neurone disease, and it's hopelessly insensitive to the rate of progression of motor neurone disease. And we need to get better with MRI, with neurophysiological markers, and with better biological markers to dissect out these forms of motor neurone disease. To come back to Edison, where I started, opportunity is missed by most people because it's dressed in overalls and looks like work. So this is not an easy field. But you don't learn to swim by sitting in the bathtub. So it is a hard field, and we're getting better at it. In our clinic, our survival data are that our patients live twice as long as when we started 15 years ago. So we need to get better at this disease because we want it to stop. I want to stop seeing 60 new people a year. That's what I want. I'll stop there because I've run just over time.